Good morning, everyone. It's a pleasure to see you and welcome to our annual meeting, our first virtual annual meeting. It's my pleasure to open the annual meeting and be able to give the tribute to Richard, which was robbed of him last year due to the postponement of our meeting. First of all, I just got to mention our admiration and appreciate to the annual general meeting team. It's been phenomenal, the amount of work they've had to do to organise this virtual meeting. As you all know, the Wales meeting in 2020 was postponed. They worked miracles to plan a virtual meeting, which was scheduled for February, and then the third wave of COVID prevented that happening and postponed to these dates in May. It is remarkable that full-time surgeons were able to adapt to virtual technology and put us on this platform for our annual meeting. And I'd just like to mention them all by name, please. Davinder Dossanj, thoracic surgeon at Heartlands and UHB. He's gone through changing hospitals as well as organising this meeting. Char Rajakaruna, cardiac surgeon in Bristol. Daisy Sanderman, lead clinical manager for the advanced practitioners here in Edinburgh. Isabel Ferner, our senior administrator, who was also working from home this year with COVID and moving from the Nuffield building to the new college building. And Tilly Mitchell, our finance administrator, and key pin for the meetings team. You have been amazing in achieving what you've done, and thank you so much from us all. I'm sorry, my slides have just all jumped forward there. That's good, thank you. As I said, it's a welcome you to our annual general meeting, and it's been phenomenal watching all colleagues in the society for their support for our specialty. The pandemic's been a major challenge for patient care, a major challenge for our personal lives, and it's been good to see all of us supporting each other and managing such significant change with a continuing desire to improve our specialty. We had our first virtual annual business meeting on March the 16th, and we presented 3 significant agenda items for you as members, and it was very pleasing to get your near unanimous support for these agenda items. And the virtual format meant that we had more attendees than ever for our annual business meeting. The 3 items were firstly to move the focus of the adult cardiac audit from the individual surgeon to the entire team and the patient pathway. It was to support our agenda and the formation of a committee on equality, diversity and inclusivity in society. And the third item was the support to write our SCTS toolkit to help units adopt best practice from around the UK to improve our patient care, to enable allied health professionals to reach their clinical potential, and to improve access to theatre for surgeons in training. Just as a reminder of what SCTS is all about, we are an inclusive professional society for all healthcare professionals involved and interested in cardiothoracic surgery. And our main purpose is described in our consultation, which is on our website. And that is to advance science in the field of cardiothoracic surgery for the benefit of the public by encouraging and promoting excellence in the practice of cardiothoracic surgery. And it's with this united purpose that we endeavour to support all members in their professional lives and reach their potential. I'm really impressed as President that the trustees and the elected trustees keep these aims and values at the forefront of all our SCTS work. The pace of change of the structure of the SCTS is remarkable and continues to develop, and now involves and supports many members at all levels and in all aspects of our specialty. And furthermore, we remain outward looking. We've had very constructive collaboration and working with the British Thoracic Society, the British Congenital Cardiac Association, the British Cardiovascular Society and the Association of Cardiothoracic Anaesthetists, and all the Royal College of Surgeons. It's been a privilege to be president and to see the work that we've achieved this year. So at last I'm able to give a tribute to Richard, the past president, President from 2018 to 2020. Richard was born 1959 in Huddersfield, West Yorkshire, and his father was a dentist and his mother was a music teacher, and he was the younger brother to Michael by 18 months. He went to King James Grammar School. He was an academic. He was a sportsman, enjoying football, hockey, squash, rock climbing, and also a musician, taking the skills from his mother at piano and guitar. It's not clear in this photograph if he's left or right-handed at golf. Hopefully he's left-handed and just about to hit the ball as opposed to having just missed it. And there's a suspicion that this was his first pint with his older brother, although the photographer was clearly more interested in focusing on the lovely car in the background. Richard was a drummer for various rock bands at school and university, and the pinnacle of his musical career was when they were the support band for Motorhead at Liverpool University. His brother went to Cardiff Medical School, going on to be a physician, and Richard wanted to go to any other medical school except where his brother was, and he had Liverpool as his third choice, only because it had a climbing wall, and that's where he qualified in 1982. And it's a fine photograph of him graduating in front of Liverpool Cathedral, in the Catholic Cathedral, and here they are with some newborns doing their obstetrics attachment. He met Meg as a junior doctor when she was a second-year student from Ireland, and it's a bizarre meeting because they met when Richard came to certify a death on the ward, which is an odd start to any courtship. And he was delighted that she should offer to give him her phone number, for him only to accidentally put it in the bin. And he had to go back to the bin and rummage through all the litter to rescue it, which was a very fortunate thing indeed. They married in 1985, and they've had 3 lovely children, Alison, Jenny and Rob. Richard trained as a surgeon in Liverpool. He got the Edinburgh FRCS in 1987, and by doing that, he achieved the GB Ong Medal for outstanding performance in that exam, which shows his academic ability. In 1989, he spent a year in Massachusetts General Boston doing research for his MS, his Master of Surgery into right ventricular failure, with Professor Buckley. He joined Liverpool as a cardiac and thoracic surgery, and made the choice to go full-time thoracic surgeon in 1998. And here he is with his team, Mike Shackloth, Julius Asante, Steve Woolley, Niraj Medurata, and sadly Susanna Love is not on this photograph, who's the other colleague. As a surgeon, he's extremely accomplished and respected as a thoracic and an esophageal surgeon, and he had the pleasure to provide thoracic surgery for the Isle of Man, with a monthly flight to do outpatients out there. He's been a major support for the charitable patient esophageal group in Liverpool. As a clinical leader, completed several terms as clinical lead for surgery from 2003 all the way to 2018, including being Associate Medical Director for Surgery, Anaesthesia and Critical Care from 2006 to 2010. Richard was a leader in the reconfiguration of esophageal surgery in Merseyside, and he did this so well it was at the expense of his own interest and excellence in esophageal surgery. He built up his own department from 3 surgeons to 7 surgeons, which is now performing greater than 1,000 cases per annum, and it's facilitated all patients in that unit now being offered VATS lung cancer surgery where possible, and now they have the recent introduction of robotic surgery. Richard is a very, very respected trainer, serving terms as Programme Director and Chairman of the STC, Specialist Training Committee. And again, there was transformation because he oversaw the merger of the Manchester and Mersey training programmes to form the Northwest Training Programme. This is a highly performing rotation, helping to train outstanding colleagues for our specialty. And from his role on the local STC, he went on to the National Specialty Advisory Committee for Cardiothoracic Surgery, 2015 to 2020. At the same time, he's been an examiner for the cardiothoracic specialty exam with JCIE, and he's the first cardiothoracic surgeon who achieved the FRCS specialty exam to have taken the exam himself. Nationally, Richard has also been a very high impact and transformational leader, particularly in thoracic surgery. For a lot of us, we remember that thoracic surgery was in its nadir, and Richard was part of a group of 4 or 5 surgeons that were present at that time, and he has been part of that leadership to take it to its thriving status. He led the Thoracic Audit and Registry from 2006 to 2014, 8 years of chasing units for their data, and he led the NHS Thoracic Surgery Clinical Reference Group from 2013 to 2016. He has led our specialty to change and separate thoracic and cardiac surgery, setting the standards for our practice. And this has clearly been associated with increasing numbers of patients being treated with thoracic surgery and improving their outcomes. As president, he oversaw the introduction of dual consultant operating cardiac surgery, which was the start of helping to move the focus away from surgeon outcomes and putting the patient first. And he's also a lead of the advisors for the Royal College of Surgeons independent review mechanism. He's a great example of successful leadership. He has accomplished major change and significant improvement for our specialty and the patients we treat. He has achieved this through data and evidence and influencing without confrontation. We saw, Lorraine and I, that he worked tirelessly as president. He was promoting the success of our specialty, protecting its reputation, personally and positively engaging members, especially when issues have arisen. Richard, thank you from all of us, from the whole specialty, and all of us have been most fortunate to benefit from your great example and your leadership. Thank you. All being well, Richard will be on live now.
Many thanks, Simon. I hope everyone can hear me. That was a lovely tribute, Simon. Thank you very much. It seems like an awful lot of things have happened that I didn't realise at the time. When the COVID pandemic broke last year and we had to cancel the SCTS annual meeting, after the dust had settled and I realised I wouldn't be able to give a presidential address, I was actually genuinely sorry. So it's great to have the opportunity to say today what I had planned to say last year, which is how proud I am of the Society and everything that it does for cardiothoracic surgical patients and for those of us who care for them. Like all leadership roles, one is hugely reliant on the rest of the team, and I couldn't have done the job without the support of many of you dialed in for the meeting today. It is impossible to mention the large number of colleagues who were so helpful, but there are a few I think deserve special mention. Simon's already mentioned the admin team, Isabel, Tilly, Letty and Emma, who were the real heartbeat of the Society. They all work very hard, many hours above their contracts, and are always helpful. A number of conversations I have had with SCTS members have shown me that they think the Society is actually a very large organisation, with legal, HR and financial departments, much like the hospitals where we work. But the admin team is actually very small, and yet they do so much for us despite the exponentially expanding workload that has come in the last decade or so. And as Simon says, especially in the last 12 months. They have the supreme advantage of having worked in the SCTS for many years, more than anyone else on the rest of the exec, which is a huge advantage when supposedly tackling new problems. So many thanks again on behalf of myself and Simon to you all. A major part of my thanks for my time as president go to two of my colleagues on the virtual stage today, Narain Mojani and Simon Kendall. Narain took over as Honorary Secretary 3 years ago and has transformed the workings and organisation of the Society with his creativity, his enthusiasm, his attention to detail, his diplomacy, but most of all his capacity for eating at work, despite the usual full-time duties of a busy consultant practice and a young family. His emails come at any time, day or night, so I still haven't worked out when he sleeps, but I assume he must do, as he is always full of fresh ideas and advice. Now, Simon I have known for many years, and since we met when we were trainees, he's been a close friend. I was very lucky to have such a superb colleague on my shoulder as president. Like Narain, he is challenging and supportive in equal measure, and he is never afraid to say what he really thinks, which even amongst cardiothoracic surgeons is actually a rare quality. His views and opinions are always based first and foremost around the interests of cardiothoracic surgical patients, with the interests of those who care for them a definite second, which is the way it should be. And this is why he's so respected as a surgeon, both in his own practice in Middlesbrough and in the numerous activities he has contributed to nationally. And I was really pleased for the SCTS when he took over from me as president. The pace of change in medicine is both staggeringly fast and painfully slow. Fast in that new treatments and technologies appear with increasing frequency, such that it is often hard to keep up. And slow in that making changes to services meet with seemingly irresolute inertia and obfuscation by those with vested interests who strive to maintain the status quo. It is only by looking back that one can see progress. I have worked in cardiothoracic surgery for 36 years. It is both harder and easier to be a cardiothoracic surgeon in 2021 than it was in 1985. Harder because there is now so much more to know. And so subspecialisation is inevitable for us to be able to continue to deliver the highest quality of services for our patients. And as Simon says, this means giving up some types of surgical practice, which have taken us many years to excel at and which we enjoy. Always hard for any surgeon, nurse, or indeed all clinicians. And as Simon says, in this regard, I believe I can claim particular expertise. But this specialisation, which is the direction being taken throughout the whole of medicine, has been the right thing to do to support the services caring for our patients, even though it is emotive for individual clinicians to give up something they have trained to do, and which they are good at. But cardiothoracic surgery is in many ways easier nowadays, in that we can see that patients are gaining much more from our care than ever before. Compare today's thoracic surgical practice with the brutality of lung cancer surgery in the 1980s, when up to 25% of patients subjected to surgery for lung cancer had an open and close operation. Many of those who had their cancers resected had early recurrences and died just as they were getting over what was often very debilitating surgery. Before CT scans were routinely available, the assessment of lung cancer operability was guided by clinical examination, a plain chest X-ray, bronchoscopy, and basic blood tests. Occasionally, a liver ultrasound and bone scan were thrown in for good measure. And no lung cancer MDTs, no specialist nurses, no effective radiotherapy or chemotherapy. Surgeons would regularly struggle with the last patient on the list to remove a locally advanced and barely resectable tumour, so that at least one patient had their lung cancer removed that day. Now the care of patients with lung cancer is much better all the way through their journey. The key improvements, especially accurate and targeted investigations and lung cancer MDTs, have been led by cardiothoracic surgeons and nurses as much as any other branch of medicine. The vast majority of patients recover from their operations very quickly, and many more can expect long-term cures from their cancers. The same improvements have been made in adult and congenital cardiac surgery, with the result that despite our patients having more complex problems and being older and frailer, the vast majority make uneventful recoveries. The days of patients dying in the operating theatre due to bleeding or heart failure are much, much less common than previously. But what is still universal, perhaps more for those of us who work in cardiac surgery than any other medical specialty, is the immediacy of the benefit we see from our care, and the huge gratitude we get from almost 100% of our patients. In the era of public scrutiny, with all its drawbacks, reflecting on how far we have come and how much better things are now than previously for our patients is always a helpful tonic. Over the last decade, the SCTS has been emphasising the benefits of teamwork for our patients. And as in all areas of cardiothoracic surgery, teamworking has improved beyond all recognition. In the 1980s, the team consisted of the consultant and a smattering of juniors. Surgeons were in competition with each other. Who could treat the most patients? Who could do the best operation? And to some extent, who had the best outcomes? One of the training posts where I learned the most, although sadly not about clinical surgery, was in a small department where there were only 2 consultant surgeons. And although they were on a 1 in 2 on-call rota, they did not speak to one another or even acknowledge each other's presence in the hospital. The nursing, perfusion, anaesthetic, cardiology and admin teams were split in half in response to the tribal loyalties that inevitably developed. And as you can imagine, the service was deeply flawed and dysfunctional. Now our teams are comprised of all those contributing to cardiothoracic surgical patient care. As a result of this, more than perhaps anything else, patient care has improved and the work is more rewarding. Nevertheless, one still hears the comment that things were so much better 20 years ago. And this particularly is the case with operative training. When Simon and I were learning our craft, we were left on our own to do many more operations than in the current era. Looking back, although this was a great way to develop our skills, there was the risk that patients would receive substandard care, which, despite all the reasons one could raise in mitigation, would be as unacceptable then as it is now. Particularly over the last 20 years, there has been the concept of lifelong education and innovation in surgical practice, which allows both newly appointed and perhaps especially senior colleagues to provide the best service for patients as long as they work together in functional teams. Now, in this context, I'm going to give you a quotation I've adapted from Arthur C. Clarke, and he's the science fiction author you may remember wrote 2001: A Space Odyssey. When a senior cardiothoracic surgeon says that something is possible, he's almost certainly right. When he says that something is impossible, he's almost certainly wrong. I'm pleased that training and team working remain at the forefront of the SCTS agenda, and I have only optimism for the future of our specialty. Having been an ambassador for the Society for several years, I know that the SCTS really does have influence at all levels. As President, I have been enormously proud of the well-deserved excellent reputation that the Society enjoys, which as a membership organisation is entirely due to its members. So many thanks to you all. And many thanks to you all as well for being such a great bunch of friends and colleagues over so many years. I look forward to the day, hopefully not too long in the future, when I can give you my thanks in person with a handshake and a drink to go with it. So thank you very much.
Richard, lovely. Thank you for those words. It was lovely to see you. I wish we could go back and start all over again. Thank you so much for all your work. You've been amazing. Thank you. We'd like to move on with the programme now and to do our Lifetime Achievement Award, sponsored by Heart Research UK. It's our pleasure, our privilege that we're here in Edinburgh and that the recipient is from Edinburgh. We've got our colleague, Richard's colleague, Mr. Steve Woolley, to do the introduction. And we'll hand over to Steve now for his recorded tribute to Bill's achievements.
I'd like to thank Heart Research UK for sponsoring this next award. It gives me great pleasure to introduce the recipient of the SCTS Lifetime Achievement Award for 2021 and indeed 2020 when he was first meant to receive this. Mr. William Walker, or Bill Walker as he is known to many, has been a true pioneer in the world of vasculopectomy. He was developing these techniques and pushing them forward at a time when many thought it was folly and would never replace thoracotomy. He deserves much respect for what he has achieved in this field, and his international reputation is well deserved. Indeed, he's still pioneering now being the first person to ever receive the SCTS Lifetime Achievement Award in a virtual fashion. Despite being well known due to his work on vasculopectomy, most people, including myself, know very little else about Bill, despite having worked with him closely and benefited from it tremendously. Therefore, in preparing this introduction, I consulted with others, but as usual, it was Bill himself who passed on the most useful knowledge that I would need. So what did I find out? Well, William Walker was born in Dundee in 1953. His father, also William, was an academic surgeon working at the unit of Professor Douglas in Dundee. It's a little known fact that the first open heart surgery in Scotland was actually performed in Dundee in the 1960s, and Bill's father was involved in this. In fact, he visited DeBakey and Cooley towards this end, and Bill tells me that his father was given an inscribed head and shoulder photo by Michael DeBakey. However, the annotation on it was slightly incorrect. It said to William S. Walker, and Bill's father's name was William F. Walker. Hence again, Bill achieved another first, being the only 9-year-old honoured by DeBakey in this fashion, even if it was a mistake. Bill went on to then study engineering at Cambridge, and I think certainly some of his engineering background led to the methodical way he worked out his technique for vasalobectomy and what was possible with stapler and camera technology in the early years. He eventually migrated to doing clinical medicine, and whilst at university he was part of the University Air Squadron, and tells me he immensely enjoyed his time performing solo flights in aerobatics. However, things didn't always go well. He did recount one story when, on a runway designed for V-bombers such as the Victor and Vulcan shown here, Bill looped his little Chipmunk aircraft straight off the runway, an event which he recalls did not go down particularly well with his superiors. He then went on to do clinical training at Middlesex Hospital in central London, and says this was a very happy hospital. He met his wife Barbara there as a student nurse, and then says he went on to develop an interest in cardiac and thoracic surgery, attending lists at London Chest and Great Ormond Street. He went on to do general surgical training in Edinburgh, and then cardiothoracic training. And these are a couple of pictures of Bill at the old Royal Infirmary in Edinburgh, where he said, again, he was very, very happy. He was eventually appointed to a consultant post in Edinburgh in 1987, and tells me he was very privileged to work with Evan Cameron, both as a trainee and then as a consultant colleague. At the time, Mr. Walker and Mr. Cameron performed adult cardiac lists, as well as all of the thoracic surgery for the unit, 80 to 90 esophageal resections a year, and Bill also worked with the ENT surgeons performing the thoracic part of pharyngolaryngectomies, mobilising and anastomosing the stomach tube, or implanting free jejunal grafts. Despite all of this, he still found time to start developing his VATS program, and in particular vasalobectomy. Now, some of you may have heard the story of how Bill performed his first vasalobectomy on the 1st of April 1992, and certainly Joel Dunning did an interview with him a few years ago, which is still available on CTSnet, and this is a picture from that interview. And for those who don't know the story, Bill says he'd already gained a reasonable amount of thoracoscopic experience in procedures such as lung biopsy, and then was confidently informed by a company representative that vasalobectomy was now very, very common in America, and everybody was doing it really. So Bill thought they could have a go at this in Edinburgh, and indeed they did, with good results. And it was only about a year or so later, when he presented these results at a conference, that he now realised he had the largest vasalobectomy experience in Europe, if not one of the largest in the world. And what he'd been told by the company vet was obviously not true at all. Now, if you look at the time when Bill started performing vasalobectomy, you can see that he's a real pioneer, and he credits his anaesthetic colleague at this time, Dr. Gordon Pugh, with carefully monitoring data on pain levels and morphine use, so they could provide some statistical proof of the benefit of the procedure. And this is a newspaper clipping from the time showing Bill's early work, really. If we go on and look at a graph of vasalobectomy in the UK, you can see that back in 1992, almost nobody was performing vasalobectomy, really. And you know, even in 2010, only 14% of loads were performed VATS. And if you look at a graph that goes up to more recently, up to 2015, for many, many years, from 1992, really up to about 2010, before things started to pick up, Bill was one of the sole advocates, really, of vasalobectomy. Many surgeons worldwide at this time were very critical of VATS, describing how it was an inferior operation, it gave no benefit. Despite this, Bill soldiered on and performed more vasalobectomies year on year and refined his technique. He also produced data on things like cost effectiveness as well as clinical results, and indeed says that he was bemused initially to find that his vasalobectomy patients appeared to have better long-term outcomes than his open patients, despite the constant criticism of this being an oncologically inferior operation. He went on to do work with immunologists looking at the response to VATS and open surgery, and indeed found there was a greater immune suppression seen with open surgery than VATS, which may help explain some of the results that he was seeing. Bill obviously became a world leader in vasalobectomy, and indeed organised many international vasculopectomy conferences in Edinburgh, as well as being an invited speaker on these topics all over the world. And here he is, being a world leader in scrubs fashion. He realised that in order for more patients to benefit from VAT surgery, he needed to train others in these techniques, and he's always been an excellent patient and supportive trainer. There are many UK surgeons who've benefited from his teaching and wisdom at various stages in their career, including myself, Joel Dunning, Johnny Ferguson, Stasha Stamenkovic, Doug West, Malcolm Wills, and I'm sure many, many others. During my time with Bill, he was an amazing trainer, and I'm sure I now bore my own trainees, telling them things such as, Mr. Walker would tell you to make sure you can see the tip of that instrument clearly when they're doing something that he and now I would not approve of. He was a true gentleman to work with, was always calm and polite no matter what the situation. And despite his achievements and success, he's always been very humble. Indeed, I can remember that shortly after starting work with him, I commented on what he had achieved with VATS as amazing, and he turned and said something to me like, well, I don't think I really do anything very special, Stephen. I just do what I think is best for the patients and what others could likely do if they wanted to. He's always put the patient first and is a firm advocate to convert a minimally invasive operation to an open operation the moment it puts the patient at more risk or becomes inferior to an open operation, which is exactly the way things should be. And this is a picture of some of the people he's trained and worked with in the past. And as we know, VATS is now the gold standard procedure for vasculopectomy in the UK, due to the work of Bill along with others, and I'm sure he's very happy we've finally got to that point after the hard slog he endured for many years trying to promote vasculopectomy. Bill's wife and son work in the pharma industry, and his daughter is a lawyer in London. In the last year since retiring, he had some time battling flooding with his farmhouse. He told me he gained experience as a trench digger dealing with this. He's also spent some time restoring a 1962 Fordson tractor and a 1982 Porsche 928, so he's veering back towards his engineering roots. I can't thank him enough for the training and support that he gave me in my own training, and I'm sure many others feel the same way. And I think many patients who are having a vasculopectomy, if they understood the contribution that Mr. Walker made to developing this technique, they would want to thank him too. So on behalf of myself and the SCTS, I think he thoroughly deserves this award and wish him the best for everything in the future. So I hand you over to Mr. William Walker. Thank you.
Okay.
Their system's not updating. For whatever reason, at their end.
Test microphone. Yeah, ready, test it.
If you leave it on it might pick up.
Okay. Very good. Excellent. Good. Welcome back, everyone. Sorry about that technical glitch. Steve, thank you very much for such a lovely tribute to Bill, who you can see standing behind me. It is, as ever, humbling to hear about one of the titans of our specialty and to hear the complete impact that, Bill, you've had to all our patients and so many of our colleagues. So it's my pleasure to present you with a certificate of Lifetime Achievement Award, Bill, and congratulations.
Thank you very much. Much appreciated.
Very good.
Thank you to the Society.
Very good. And we also have an engraved decanter, which we hope is more useful than the certificate.
Thank you.
Thank you, and thank you for being here. It's a lovely coincidence that we're never able to do it personally.
Look forward to the decanter as well. Thank you.
And I hope you'll wait for a coffee afterwards. Thank you. Lovely. We will move on with the programme. Thank you, Bill. So we'll now move on to Bill's presentation, which he recorded before.
Good morning, everyone, and I'd like to thank the Society for giving us the opportunity to present this work on international missions. And importantly, I'm doing this presentation on behalf of the large team that you can see who made this work possible. So what's the problem we're trying to address? The key thing is that there is a significant underprovision of cardiac surgery in low and middle income countries. In Africa, there's one cardiac surgeon for every 1 million people, and less than 10 countries have a cardiac surgery unit. The main problem is rheumatic heart valve disease, and this is the only paper that I'm going to show in this talk. This is the Valve Afrique study, which looked at echoes in 3,400 patients in 7 sub-Saharan countries over an 8-year period. And the following take-home messages were arrived at. The first is that the majority of patients are young, female, and many of them fail to become educated and hence contribute to their economies and their societies. 40% of patients had significant valve lesions as a result of their rheumatic heart disease, and 38% of those valve lesions were leading to clinical sequelae. Importantly, 1,200 patients had indications which we would use from current guidelines to mandate surgical treatment. And over the follow-up period of 8 years, only 27 out of those 1,200 patients ended up having any surgery. And that alone demonstrates the gap that we're trying to address. A number of years ago, AATS, STS, EACS, and a number of other international societies got together to form the Cardiac Surgery Inter-Society Alliance. And the Cape Town Declaration on Access to Cardiac Surgery in the Developing World was published simultaneously in all the cardiothoracic journals. This is the first meeting of the Ghana mission team in 2018. And the most important message is that it's very much a team effort. The surgeon is a very small part of delivering cardiac surgery in this setting. And clearly the work and training that needs to go into delivering anesthesia, perfusion, intensive care, nursing support, theatre nursing support, etc., are really very important. One of the key challenges is fundraising, and we adopted a strategy where we only raised money within our Teesside community. We have a really good relationship with the wider Teesside community at James Cook, and we exploited that for this mission. And amazingly, in the 2 years that we were raising money for Ghana mission, we raised over £50,000 in the Teesside community. The other key issue, of course, is logistics. This is a container leaving my house in the middle of winter. The team had packed all the equipment we needed, loaded it onto the trailer, and this trailer was heading down to London to board a ship, which would then deliver it to Accra and then on to Kumasi, where the mission was to take place. And we literally had to take everything we needed to deliver a cardiac surgery program on that container. Our first mission was in 2019, in February, and we did a number of procedures. It became quite clear that a really important need was a permanent pacemaker service, because there wasn't one in Ghana, and there were lots of patients turning up with heart block, collapse, sudden death, with no access to permanent pacing. That was clearly something that had to be addressed as well. The key thing is collaboration with the local team. You just don't turn up and decide what they need. It's really important to work very closely with them. And we did a lot of work engaging the management of the hospital and the wider health community to put together a plan towards a sustainable cardiac surgery unit in Kumasi. The plan had a number of really key elements. The first is that the Ghanaian team needed to be trained, and we elected to do that by bringing them to Teesside. This was clearly a major undertaking. It involved money, it involved a lot of regulatory approval, immigration issues, etc. But we felt that if we could achieve this, we could make a very, very big impact very, very quickly. We needed to build capacity by involving other teams. The Boston Children's Hospital agreed to join us to really do some work on the pediatric side, which we weren't equipped to do. Cardiostat USA, led by Emily Farkas, who many of you who do this sort of work would have come across, also agreed to partner with us. And then finally, David Adams's unit in Mount Sinai also agreed to partner with us. So we conducted 3 missions, our missions in February and October. Cardiostat performed a mission in January. And then we had other missions penciled in the diary for the other teams, with the aim of developing sustainability and independence over a period of 2 years. We did manage to get the Ghanaians to come to Teesside, and that really was a huge breakthrough. We were able to train them in the lab and in theatre. We were able to do didactic training. We were able to do team-based training, and we were able to equip them with what they needed to work on their own as a team. When they went back, we followed up with a mission 4 weeks later in October 2018. And the most important thing about this second mission was that it was all about getting the Ghanaian team to perform a heart operation on their own without us for the first time. And this video shows what happened to that first ever patient who they operated on. Good. So, we've had a wonderful day. Can I introduce Isaac Ochu, who you've met several times on our blogs. He's a surgeon here at Fundraising, and Bafu Jan is a cardiothoracic consultant from Accra. And today, they have been operating together and doing the first Ghana-only team cardiac case. We've been working towards this for 6 months.
Absolutely.
It feels like we've achieved a lot in 6 months' time. So we're very pleased that the patient has been operated on and they've now come to intensive care unit. So well done to you guys. That's a really big leap forward.
Thank you. Isaac, how do you feel?
Exhausted. It's great because we never thought this was going to be possible. So that when we returned from UK, we're thinking, we used to meet and think about, can we do this thing? Can we do this thing? So we are very excited that we're able to do this thing.
And how did you get on from you?
So I still get goosebumps when I watch that, watching them do the first case on their own for the first time. That was incredible and a really big leap forward. Of course, then this happened and we haven't been able to go back. What's the point of the missions working group? Well, there must be a lot of you out there who want to do this. We know that there's several groups out there who already go out in the developing world to do this work. Our initial expression of interest yielded 70 responses. And despite COVID, the need remains, and even more so. So we want to recognize and promote the work that people are doing. We want to be able to engage with the Cardiac Surgery Inter-Society Alliance to help achieve their aims. And we know that SCTS can add huge value to this work, whether it's education, professional standards, training, or audit. So I'd like to end this presentation by getting the team to tell you what the impacts it had on them. Thank you very much for your attention, and thank you very much for the opportunity to present this work.
Ghana is considered to be one of the more stable countries in West Africa, but it still has its fair share of problems. Thousands of people pour into the hospital here in Kumasi every day, but very few people with severe heart problems will receive the help they need. Medics from the northeast raised money to be here for a week. This is the last operation the team from Teesside are doing before going home, while here in West Africa, they've been saving their patients' lives. But it's also been about training the local medics.
Only some useless surgeon put them in. Right now you need the retractor. They're internal paddles, so you pretend they're there. We're going to try and bring a team of Ghanaians back to James Cook and train them so that when they come back here, they really will have the skills to look after their patients. We don't want to be here for one mission. We want to be here to start them doing regular surgery.
We hope that this collaboration is going to grow very well, and therefore we have the hope that we're able to have more assistance from them in terms of skill acquisition, and then we're able to do things on our own here in Ghana.
They've had to improvise whilst they're out here.
Do you normally talk on a Glover route?
At home?
Yeah.
No, not at all. But it's okay, it works and that's fine. We have it at home, we have our own sterile container that we slide the battery into.
I filmed Andy from Darlington at James Cook Hospital in Middlesbrough a few weeks ago when he was giving Arthur a new pacemaker.
Well, I think this team are brilliant.
Here in Ghana, he's been doing the same for patients like Thomas.
Well, I think they can help me to live longer.
We had a patient who was quite unwell and quite sick, whose heart rhythm kept going into a very dangerous heart rhythm. And that's when you suddenly realise you're on your own and you've not got your normal team around you to help you. So that all worked out fine in the end. But it's issues like that where you suddenly realise you're in Africa, not back at home in Middlesbrough.
Peter is a nurse from Middlesbrough who loves the impact he's made out here.
We've had electrical issues, which doesn't happen at home, but it's been amazing. The whole thing, the staff here is so enthusiastic, so eager to learn, which is fantastic, and it's made us feel really welcome. And it's an honour to be here. It's an absolute pleasure, and I'm so happy, proud that I've been given the opportunity. So.
It's time to go home. Another trip is already being planned. Jonathan Swingler, Beauty Look North, Ghana.
That's why I was, well, that's why I was saying to kind of do it from here, guys.
Absolutely excellent and amazing to hear. It was so humbling, and it just shows the kind of work which you, Joel, and your team has been doing in the interest of patients of a different country. For colleagues who don't know Enoch, Enoch is a consultant cardiac surgeon in Middlesbrough. He has incredible amount of energy. Besides being an excellent cardiac surgeon with special interest in minimal invasive mitral surgery, he's also led on several national clinical trials, and he's also contributing to in leadership role within the SCTS as the chair of the cardiac subcommittee, and is really impacting on some of the big national agendas in cardiac surgery in the UK. So thank you very much, Enoch, and it was a pleasure to see you. Okay, and I'm sorry about the technical glitch. We're going to have Mr. Bill Walker's presentation right at the end, after Clinton's presentation, so I'm sorry about that. And next we move on to Anil Pangu. Anil is a senior lecturer at the University of Birmingham. He's a consultant colorectal surgeon. We've all had a very challenging time last year in relation to COVID. And Anil is also a founding member of the Global Surgery Collaborative, and he's going to talk to us about supporting safe surgery in COVID 2021. So can we have the presentation on supporting safe surgery, please, from Anil Pangu? Thank you.
Hi, my name's Anil Pangu. I'm a consultant at the University of Birmingham, and I'm the chief investigator of the COVID Surge Collaborative. It's a pleasure to be talking to you today about what the collaborative is and what the key messages are. And I've got one of the other principal investigators here, who is Mr. James Glasby, who is a surgical registrar and NRHR PhD fellow. Hello, James.
Hi, Anil. Nice to be here.
So I'm going to do the first part. I'm going to talk to you about what it's all about and how we did it. And then James is going to come in with some of the data-driven messages, the key practice messages. So I'm just going to share my screen. We'll talk to you for about 15 minutes, if that's okay. Am I full screen there, James?
Yep.
Okay. So we sort of, when COVID hit, we started this up, and several of the charities across the UK were kind enough to support our very rapid research response, which I'll come to in a minute, but they're just listed here. But we started this, I mean, we're natural network builders in Birmingham University in the Department of Surgery. And we started putting collaboratives together back in sort of 2008. And this is what it looked like, a bit rough and ready. Within a few years, there was complete national coverage and independence of subspecialty groups, which is great. We pushed that wide, and we went to see how far globally we could go. And what we tried to do is connect surgeons globally. What we've ended up with is a network that can deliver faster research for patients. At that stage in our data studies, we were already working across thousands of frontline medical personnel over hundreds of countries. And within that, we've got a trials network, which I'll talk about. And then what we did once a year when we could is meet face to face and prioritize new research. So the frontline surgeons from these countries, our partner countries, would prioritize research, and we would add in the methodology and governance needed to deliver research. And then in 2017, we were core funded by the NIHR to be the UK's world's first fully funded global surgery research unit. This is how we publish all of our papers. They're under one corporate name with everybody listed at the end, and that works really well for us. For the surgeons who are listening, we have now figured out that 1 in 3 surgeons can't spell their names right the first, second, or third time, but we'll sort of just keep going. But what we did there is develop a portfolio of randomized trials. So the first 2, Falcon and Cheetah, are looking at wound infections. Penguin's working with the anaesthetist, looking at oxygenation, and Crane is looking at cancer surgery and nutrition. And these are, COVID has really made the randomized trial fashionable again due to recovery. But these started just before then, and they actually accelerated during COVID. But Falcon, 5,500 patients in 18 months. Cheetah, in about 15 months, it would have recruited a total of 20,000 patients. These are mega surgical trials. It's nice to give them animal names, have little cartoons. I am aware that the mortality rate of patients in these studies is very high. So we're trying to tackle these quite big, serious global problems. But as a result of that, what we did is we always had responsiveness, the idea that if people would tell us what to do, and we add the methodology. So when COVID hit, we suddenly had surgeons from around the world saying to us, well, what do we do? Is it safe to keep operating? What is this and what does it mean? So we launched a research response using our infrastructure here and some charity funding. And we very quickly put together a network that's bigger than this. The N network has resulted in a data set of over 200,000 patients and data changing messages. And it's quite unique to be in that position after only a year of launching a research study. So I'm just going to talk to you about our first couple, and then I'm going to hand over to James. But very early on, we did a modelling study on the number of elective operations cancelled, and with just in the first wave, there were at least 28 million operations cancelled around the world. And this was our first step into what I call the public domain, because this stuff picked up a lot of media interest, ranging from the Mail Online to The Economist, and quite high Altmetric scores. But that just goes to show that actually this stuff is of public interest. And as we continued, we always decided to try and appeal to the general public. And so our next study was a prospective cohort study of patients having an operation who had a pre or post-op diagnosis of SARS-CoV-2. And that first paper unpicked that disease phenotype in the Lancet. And it was great to get into the Lancet in those days. Very rarely does one get to define a new sort of disease phenotype like this. But I do point out that the mortality rate was 24% at 30 days, and that includes patients undergoing major and minor surgery. And these mortality rates are higher than any aneurysm surgery, higher than the emergency laparotomy rate. So although it's great to get into big journals, this very muted celebration because it was on the basis of a lot of misery. But this did identify to surgeons they need to be very careful in who they are operating on during the COVID era. So that was a very quick start point where we got to, and then we've unfurled this more complicated series of studies. So James, I'm gonna hand over to you to talk about the next studies, and I will stay in control of the slides. So good luck.
Thanks. So the next logical step in this sort of pathway of data-driven decision making was, what can we do to protect patients from these risks of perioperative SARS-CoV-2 infection? And one strategy that was emerging around the world was this idea of a COVID-19 free surgical pathway, also known as a cold site or green pathway. And we define that as having a hospital pathway that was completely segregated away from areas that were treating or admitting COVID-19 patients, and where any area was mixed with patients that had COVID-19, this was defined as an area with no defined pathway. And in the early phase of the pandemic, when we were first looking at this, this was not a universal solution. About 1 in 5 hospitals had provided this pathway for their patients. And what we found really robustly was that the COVID-19 free pathway, these cold sites, reduced the risk of pulmonary complications and SARS-CoV-2 infection for patients. And that worked in lots of different sensitivity analyses. So it worked for minor and major surgery and in both high and low risk areas. So even when the community transmission rates dropped off, there was still this really clear benefit. And why is that important? Well, these things are very logistically and financially challenging to impose in hospitals around the world. So provided for the first time evidence their effectiveness. Next slide, please, Anil. Alongside these cold pathways, of course, everyone was wondering about whether we should test patients or not. And in this study, COVID surge cancer, that was done between March and August last year, there was a really low testing rate. About, again, 1 in 5 patients were getting tested before surgery. But having this testing strategy with nasopharyngeal swabs and PCR testing actually reduced the rate of pulmonary complications for those patients that had a swab. And we hypothesized that was because you could identify patients with pre-symptomatic or asymptomatic infection and then delay their surgery for later, so they weren't being captured within the cohort. And we looked at the different effects of testing in different groups of patients. We saw that in high-risk areas for both major and minor surgery, there was this really compelling benefit for routinely nasal swabbing patients before surgery. So you could avoid 1 pulmonary complication for every 20 patients tested before major surgery. So this, massive effect. In low risk areas, there was still a really strong benefit before major surgery, but less before minor surgery. So this provided important evidence for the universal uptake of testing, and perhaps suggested that for minor surgery in low risk areas, counselling patients on the day of surgery if they've not had a swab may not necessarily be appropriate. Next slide, please, Neil. So our sort of next question that was rose from the network was, what should we do if we identify these patients that are asymptomatic and have a positive swab test? And we got some early data from our first cohort study that suggested an increased risk of pulmonary complications for patients that had a historic infection. Fortunately, that risk seemed to diminish over time. And in just 150 patients with this asymptomatic infection, we're able to show that risk roughly returned to baseline after a month or so. But this was not a definitive study. So in order to address this completely, we sought to undertake a collaboration across 2 networks, bringing together COVID Surge, this responsive network, with Global Surge, our global surgery network. And we conducted a project called Surge Week, which we think is one of the largest scientific collaborations of all time, involving 15,000 collaborating surgeons from 116 countries to collect prospective data on almost 200,000 patients. And this answered really robustly this really important question and showed that for patients with an asymptomatic infection, you should delay them for 7 weeks or more. And if they're still symptomatic at 7 weeks, then you should delay them a little longer still. So really crucial data, particularly with an emerging group of patients that have had a previous infection. So the final thing that we've been working on with the data to date is around risk stratification for patients. And we've been collaborating with the machine learning team through Health Data Research UK to create complex models that will help risk stratify patients based on their risk of pulmonary complications. And this is now available online at covidsurgerisk.app and is being published in the British Journal of Surgery shortly, but allows you to estimate a risk for patients before surgery to help guide decision-making about whether surgery should be delayed and to try and rationalize resources appropriately.
Hold on, bear with me, Professor Whitty. There we go.
Finally, using this data, we've also been able to do some modeling studies to answer questions where we didn't have direct data available. And the first one was around whether or not surgical patients should be prioritized ahead of sort of age and sex matched patients from the general population. And what we showed in this paper in the BJS was that actually your return on investment for vaccinating surgical patients, particularly those undergoing cancer surgery, for example, was much better for patients undergoing surgery than age and sex matched people in the general population. And so we've been working with the UKVI, the Vaccines Initiative, through the Royal College of Surgeons to try and activate this. And in the UK, there is quite a rapid rate of vaccination, but on a global scale, it will be several months until universal vaccination is available. So we hope that this data will be really useful to improving surgical safety across different contexts. Back over to you, Anil.
Thanks, James. Just to finish, so we also pushed forward some patient-facing material led by one of our team from Queen Mary, University of London, Mary Venn. And this material was devised with patients and has been downloaded over 24,000 times. And it's available in 26 different language formats. And so again, it's just about pushing data in different directions. We've come out with 7 practice-changing messages, and they're embedded in the policy section of our policy website, which is on the screen there. And we've got some high visual reports that aren't presented like papers. They really get to the key message. They're more presented for policymakers, and so you might enjoy looking at those for a higher level, quick view of what the core messages are. But what we have learned is that there was traditionally publication and sort of a presentation somewhere, and then things would stop. What we want to get to now is practice change and public engagement. And we're flowing down this pathway to do it. COVID surges close the gap, but we want to close the gap further. Gone are the days where there's a year of analysis, a year to get a paper published, the paper's behind a paywall. Within 30 days of finishing an analysis, we'll have done a webinar, we'll have that on YouTube. We publish everything open access, we create visual abstracts, and we're finding newer ways to close the practice change. And our final way via that website will be to create a digital CPD CME portfolio where you can do 3 or 4 hours on COVID surge, and it will be certified and held digitally. But we'll expand that, and in our world, we'll do it across appendicitis, cancers, vascular disease, bones. We'd be delighted to hear about whether you think we should be doing modules on really what the latest cutting edge research is and how you can learn about that very quickly. So you'll go to different websites to learn how to do an operation, and this is where you'll go to learn about the latest research data. So thanks very much. That's where we've got to. We are looking to publish our data from the COVID surge cancer project, which James has led. And James, you're about ready to submit that?
Yes, just ready to submit the paper from the final lot data set. And we've also provided the thoracic steering team led by John Edwards from Sheffield with the thoracic data. So I believe they're looking specifically at thoracic cancer analysis at present.
And the urologists have got data as well. The urology team have got the data as well. So we're expecting to see thoracic, urology outputs, colorectal outputs. We're moving forward with the breast output as well. So every individual cancer should have a specific output. But the overall study is going to look at the effect of lockdowns on whether cancer surgery that was promised got done or not. So that's, again, we're going for quite a public interest message there, which we'll look to get out as soon as possible. But in the meantime, thanks very much for listening, and please keep an eye out for future studies, because we are probably going to do a sort of post-pandemic cohort in 2022. Okay, thanks very much. Thanks, James.
Thanks, everybody.
Really insightful into some of the work that you've been doing relating to surgery and response to the COVID pandemic. It gives me great pleasure also to introduce our next speaker, Davinder Dossanj, who also works at the University Hospitals in Birmingham as a consultant respiratory physician and also an honorary senior lecturer there at the university. He's heavily involved in many of the research projects that have already been described, and he's going to be today giving us some insights from firefighting during the COVID pandemic, and also some of the lessons learned about how we move forward in our clinical practice. Davinder, please, over to you.
My name is Davinder Dossanj, and I'm a respiratory physician at the Queen Elizabeth Hospital, Birmingham in the UK. I'd like to thank the organisers for asking me to speak at the SCTS. It's a real privilege for me. Briefly, these are my disclosures, none of which are relevant to this talk. I was asked to give a 10-minute talk on my reflections as a frontline COVID doctor. What qualifies me for this? As you can see from the graph, at UHB, we've been dealing with COVID since March 2020 and have been at the epicentre of the COVID response in the Midlands, dealing with 2 large surges of COVID-related disease. We've managed over 5,000 COVID-positive patients to date and have cared for the largest cohort of intubated patients with COVID disease in Europe. So whilst COVID has no doubt been a large, dark cloud over the past year for everyone around the world, there seems to be a small glimmer of hope for the future. Given this, I wanted to focus on some of the silver linings that COVID has presented to us, rather than rehearse the multiple ills that COVID has rained down upon us. Having said that, as illustrated by this graph from the FT, the COVID pandemic is by no means over, and I don't wish to diminish the severity of the situation or the devastating impact that COVID continues to have on communities all around the globe. Whilst the UK is in a lull at the moment, we should not forget the horrors that our colleagues are facing around the rest of the world, in particular the rest of Europe, Latin America, and India. The challenges that we have faced over the past year have nonetheless provided us with opportunities, and I'm going to speak about some of those over the next few minutes. The first area I'd like to touch on is the remarkable focus and effort that the global scientific community has placed on COVID research over the past year and a half. It's important not to forget that the first reports of COVID-19 disease were only published in November 2019. Since then, over 130,000 research articles have been published on the topic. Whilst I concede that not all of these articles will have revolutionized our understanding or treatment of the virus, the sheer volume of articles published is astounding. And of those articles that have been published, the almost miraculous thing is that all the major journals made all COVID-related publications open access. Before the pandemic hit, this would have been completely unthinkable. Whilst open access journals were slowly on the rise, to see the likes of Lancet, New England Journal, Nature, JAMA, etc., making all of their COVID-related data free to view has revolutionized how we have practiced medicine over the past year. And along with this open access revolution has come the rise of the preprint server. This repository of papers has expanded almost exponentially since the pandemic has been declared, and whilst no doubt the servers come with their own problems, i.e. lack of peer review being the main issue, it has enabled real-time access to cutting-edge research without the usual delay that the traditional publication process introduces. It also eliminates the inherent problems with peer review, allowing the reader to decide whether the data is valid or not. Out of all of the studies, I'd like to highlight 2 in particular that I think we as a community should be particularly proud of. The first is the recovery trial. This is the largest randomized controlled trial investigating the efficacy of interventions for patients with COVID-related disease in the world, and it is being run by Professor Landry and his team from the Nuffield Department of Medicine at the University of Oxford. The importance of this work cannot be underplayed. There are 181 actively recruiting sites, and the trial includes data from almost 40,000 participants. It's reported on the efficacy of azithromycin, convalescent plasma, dexamethasone, hydroxychloroquine, lopinavir, ritonavir, and tocilizumab. As a result of this trial, we've identified the only 2 treatments that have shown undisputable efficacy in COVID-19 disease, dexamethasone and tocilizumab. No doubt there are other promising therapeutic interventions that have been investigated in other trials, but the recovery trial has been the only study to give us undisputable data thus far, and as a result has likely saved countless lives. It's not only the great and the good that have been galvanized to do COVID-related research. In this slide, I have provided a selection of some of the publications that the respiratory team at UHB have contributed towards. COVID has provided us with the opportunity to develop and hone all of our research skills. I would say that never before has an understanding of data and research methods been more important to the clinician on the ground, and COVID has shown us that medical research is not the preserve of the professors in their ivory towers with protected research time in their job plans. It is the jobbing shop floor clinician that has made all of these papers, publications and breakthroughs in therapy possible. One of our studies has even been provided as evidence to influence policy in the UK Parliament, something which I never thought I would ever be able to contribute to. We should never again forget that we all have a responsibility to contribute to the knowledge and evidence base for the patients that we care for. As a specific example of this, I want to mention the Recovery RS trial, an RCT investigating the use of high-flow nasal oxygen and continuous positive airway pressure in those with severe COVID-19 related respiratory failure. This is the largest ever trial of non-invasive ventilation and respiratory failure being run by Professor Gavin Perkins and the team at Warwick. UHB commenced recruitment for this trial in April 2020. Before January 2021, only 33% of patients who were commenced on high flow or CPAP at QHB did so via trial recruitment and randomization. The clinicians recognized this as a concern. We were managing patients with interventions without an evidence base when we had the opportunity to recruit to a trial and help contribute to that evidence base. We set up a clinical care pathway and respiratory support unit outside of the ITU setting to relieve critical care pressures, but also to optimize recruitment to this study. Post-RSU setup, 100% of patients who commenced on non-invasive ventilatory support did so via trial recruitment and randomization. As a consequence of this, UHB was by far the largest recruiting trust to this trial nationwide, enabling the trial to close recruitment, and we now await the outcome data. Another opportunity that COVID has provided for us is training. Now, no doubt you will have heard and experienced the multiple cries of anguish from trainees and trainers alike regarding the loss of training experience for our specialist trainees. However, to put a more positive spin on this, the COVID pandemic has provided the inspiration for the respiratory trainees in the West Midlands to submit their first trainee-led paper for peer review and publication. Dhruv Parekh and I established ResPract well over 2 years ago in order to mimic the successes of the Surgical Trainee Research Collaborative and undertake research and publish multi-centre studies driven by the trainees themselves. It's fair to say we were floundering due to a lack of engagement from the trainees. When COVID struck, however, the respiratory trainees of the West Midlands, despite being at the forefront of the COVID fight, were inspired and enthused enough to gather data on more than 2,000 COVID positive patients from across the region to assess the utility of severity assessment scores at the time of admission to hospital. The analysis revealed that none of the scoring systems commonly in use were any good at predicting poor outcomes, but the glimmer of hope here is that the trainees engaged with the research process and gathered important data which will hopefully be published very soon. An amazing feat given the stresses and strains they have all experienced over the past 18 months. And it's not just the research and medical community that have experienced a renaissance. Since the outbreak of COVID-19, communities around the country in the UK have sprung into action, and no doubt that's not unique to the UK. Neighbours are connecting and looking out for each other more than usual. Informal support groups in local areas have organised to support people in need, and now there are over 2,000 groups listed on the mutual aid website established by the UK during the pandemic. And I think these figures from the Office for National Statistics of the UK are particularly heartwarming. This data is from a survey the ONS carried out in April 2020, and it shows that 64% of people thought that other local community members would support them if they needed help. Almost 80% of people were doing more to help others since the pandemic. 62% checked in on neighbours at least once in the last 7 days, and almost 40% had gone shopping or done other tasks for neighbours. Finally, I want to touch on the fantastic multidisciplinary approach that we have had to take during the pandemic. Whilst there was much lip service to the concept of the MDT pre-pandemic, certainly our pandemic experience has cemented the utmost importance of this approach in the work that we do in the hospital. Whilst the care for patients in the intensive care unit was transformed due to staffing shortages and the vast quantities of patients requiring level 3 care, it meant that we on the wards were looking after patients that had been discharged from ITU a lot sooner than they would have been under normal circumstances. This required a true MDT to ensure that the patients received safe and effective care both whilst they were deteriorating and heading towards ITU, but also once they had been discharged from critical care. The specific challenges these patients faced included tracheostomies, profound sarcopenia, hospital-acquired infections, and the list went on. We set up a multidisciplinary service which included respiratory physicians and registrars, the physiotherapy service, the ear, nose and throat surgeons and speech and language therapists, ITU outreach including consultant reviews when required, respiratory trained nursing staff, and we even provided renal replacement therapy on the respiratory wards to aid quick ITU discharge. And once the focus of care moved to rehab, we shifted our focus and geriatricians became the main leads of care. There was still ongoing input from the respiratory team, but also there was enhanced multidisciplinary team meeting, neurorehabilitation, plastics, and the hip fracture ward nurses became crucial to the rehab process. We also used medical students to help with communication between the hospital and the relatives who weren't allowed to visit their patients. I think it's fair to say that without the mutual love, respect, and support of colleagues within and outside my department, I would not have been able to make it through the last 18 months. We sometimes forget how long we've been trying to cope with this problem, and looking back at some of the photos, it almost seems like we were having fun. I've forged relationships that will last forever and have memories which will both comfort and haunt me for years to come. And it's the memories of my colleagues from the whole MDT that will stay with me for the rest of my life. I have to make a special mention here regarding our thoracic surgical colleagues. This is Mr. Fallu, dressed in his full PPE on our critical care unit, ready to help in whatever way he can. Mr. Calcat was also redeployed to ITU, and he was invaluable in the support that he provided to critical care. He was helping to nurse patients. He'd then move on to inserting a surgical chest drain for another patient and then go back to nursing another patient. There was a true bonfire of the silos during COVID and a spirit of cooperation which I'd never seen before, which spanned all the disciplines and specialties, and COVID helped to bring that about. Long may that continue. Thank you very much for listening. I really hope that you found the last 10 minutes or so of some interest or value, and thank you once again for inviting me to speak to you all today.
You to do the next introduction.
Helen, please.
Thank you. Good morning. I'm delighted to welcome our next speaker, Felicia Kwaku, who is Associate Director of Nursing for Quality Improvement at King's College Hospital in London, Chair of the Chief Nursing Officer's Black and Minority Ethnic Strategic Advisory Group for NHS England. And Felicia was recognised for her services to nursing during the COVID-19 pandemic and awarded an OBE in the Queen's Birthday Honours List in 2020. In recognition for what she had done for her Black, Asian and minority ethnic nurse colleagues when it became clear that these groups of nurses were being disproportionately affected by the virus. Felicia delivered webinars which reached thousands of nurses at a time when they felt vulnerable, scared and worried. Felicia has spoken up loudly and decisively about the need for appropriate risk assessments and PPE for nursing staff and other clinical colleagues. Thank you very much and welcome to Felicia.
Good morning, everybody. My name is Felicia Kwaku. I am currently a Associate Director of Nursing at King's College Hospital, London, but I'm also the Chair of the Chief Nursing Officers for England Black Minority Ethnic Strategic Advisory Group. And I'm here to talk about reflections and experiences during the COVID-19 pandemic. In this first slide, you will see that this is an image of the staff that had died in wave 1. You'll see there were a mixture of doctors, nurses and porters. If you look closely, you will also see that the majority of staff that you see in this slide are from an ethnic background. And this gentleman here is Dr. Alpha Sadhu, a colleague and a friend of mine who died. He was one of the first 10 doctors that died in wave 1. Why is it important? Why am I here? I'm here because early on in April, May, we had 2 seminal reports. One report was from the Office of National Statistics, and the second report was from the Institute of Fiscal Studies. And it started to identify some worrying evidence. It identified that were some ethnic groups more vulnerable to COVID-19 than others. And it also identified that the staff and communities were dying from COVID that applied to the ethnic staff and communities from an ethnic background. So why is this important? It's important because out of the 1.2 million NHS staff, 40% of those doctors come from an ethnic background and 20% of nurses come from an ethnic background. So it's really important to put that in context, and you will see on the graph on the right-hand side that ethnic minority communities are not a homogeneous group, and you see that the different rates for death amongst ethnic communities, and we saw the highest deaths amongst the Black Caribbean and the Black African communities, and we also saw high amounts of death in the Asian community. So for Black communities, it was 4.2, 4.3%, and for Asian communities, it was 2.8, 2.9. So how does that then apply to the workforce working during the time of COVID? This is a slide from June last year, and you will see at that time there were 216 staff that working in the NHS that had died, and out of those staff, 199 died as they were working in an inpatient setting, and 17 members of staff died in the, if you like, community setting. When you looked at the age group profile, the majority of deaths occurred between 56 and 65 years old. But what was more shocking is that the largest group of staff to die were from a Black and minority ethnic background, and 62% of staff at that time that had died came from an ethnic background. And this was quite shocking for everybody, and it's especially shocking if you were from an ethnic background. Why is this important? It's important in the context that where are these staff placed then, staff from ethnic backgrounds? And this slide is taken from the Workforce Rate Equality Standard, which looks at the experience of staff from ethnic backgrounds compared to their white colleagues. And the red bars are the ethnic minority staff, and you will see that they're predominantly clustered in band 5 positions. And at these lower bands, you'll note that staff are much more exposed to patients, therefore much more exposed to a high viral load. You will also note that they were also clustered, which is not shown on here, in bands 1 to 4. So we would say that those staff are much more vulnerable because their contact with the patients is much higher. So staff also at that time began to report to us some concerns around their experience during COVID. They started to tell us that they felt unsafe. They were very anxious and frightened and scared. So as the chair of the SAG group, we needed to really hear their experiences firsthand. So we commissioned a series of engagement events as telephone conferences where we met with nearly 2,000 staff. We met with them virtually, and we covered the whole of England and the 7 regions across the NHS footprint. So that resulted in 9 telephone conferences between April and May, and we also hosted a session for educators and for students. And so what did they tell us? They told us that if you were agency nurses, that you were very vulnerable. You didn't have access to the structures that that staff had that working in the NHS. They felt vulnerable, not protected. There were lots of misinformation, lots of mythology, lots of untruths. There was issues around safeguarding. They felt that they were being discriminated against. Trauma, anxiety, and fear was a real compounding problem. They felt very traumatized because they felt unsafe. There was a big issue with PPE, personal protective equipment. So issues around staff being told to go and work in areas, wards, nursing homes, etc., without the requisite PPE. Staff being told to work with insufficient PPE. And also we identified there were issues with the FFP3 mask in that for some of our Asian colleagues, the masks didn't fit very well because the masks were made for white Caucasian males. There was also an issue with risk assessments. So the original risk assessments did not reflect ethnicity, and staff told us that they had problems accessing COVID-19 testing. So what did we do? We wrote up a report based on the engagement sessions and the feedback and intelligence from the ground floor staff. And these, you will see on the slide, are a list of recommendations. So we made recommendations around any staff death that should have a formal review. We asked organisations to do workforce modelling around ethnic staff. We asked for research and more in-depth audits around PPE equipment. It was really important that staff had access to spiritual care and that any mental health provision was culturally sensitive so that staff could feel open to able to talk to that level of experts. It was really important that we got the right level of information to staff, and we are also drafting an app at the moment so that staff can get the right level of information. And it was really important that staff felt safe, that they could raise up concerns without the feeling of being persecuted. So all of these recommendations fed into a national plan for ethnic minority nurses and midwives that would strengthen their position, but also protect them in terms of their health and well-being. And so you will see that there were 5 work streams that the NHS England have started, and that is around protecting staff, engaging with staff and their networks, having a real representation in decision making, ensuring that staff have proper rehabilitation and recovery, and that there is really good and effective and efficient comms, and that there's a media presence around ethnic minority staff. So this is the kind of experience that we went through. Staff were redeployed from certain areas into the critical care areas. We saw great teamwork, worked long, hard hours. There was a lot of death. Patients died very quickly. Staff sickness was very high at the time as well. We opened, we closed wards. We had a command and control structure from the central offices and central control. We had a really, in the end, robust swabbing and protocols around infection control. And we started to see really good psychological services and counselling support for staff. So in the second wave, what we experienced was it felt worse in the second wave. We saw that the speed and spread of death was much faster. We saw the speed and spread of the virus this time around was much quicker as well. We started to see the emergence of long COVID, and that was impacted, of course, with all these variants. But we started to see that we had the vaccine, although there was lots of hesitancy with the vaccine. Staff by this time were utterly exhausted after having gone through the first wave and the second wave. And then there was a feeling of moral injury because staff were being asked to do things that they had never been asked to do before and hadn't been trained to do before. The sickness remained high, and that was across all the disciplines. And I think the most shocking thing was really the amount of nurses and other healthcare workers that were dying, and they are still dying. And I remember the first week of February, we had 10 staff deaths. Predominantly of those were nurses, and at least 70% of those nurses and midwives were from a Black, Asian and ethnic minority background. So those are the shocking things. So that's really our experience so far. And I think we are all bracing ourselves that we have time to breathe at the moment, but we are really cognizant that there may be a third wave and how we need to prepare for that. So that is the experience I wanted to bring with you today, and I thank you very much.
Helpful to understand the impact that it's had on the nursing community and also the things that have been done to try and protect those that are the most vulnerable. So thank you for that really impressive presentation. Next, we're going to move on to talk about the new SCTS website. It gives me real pleasure. It's a project that we've been working on for the past 2 years, and it gives me real pleasure to talk to you about it, that we've just launched it. I'm going to introduce a colleague of mine, Clinton Lloyd, who's a consultant cardiac surgeon in Derriford, who has been working tirelessly over the past 18 months to make this project go live. And he'll introduce you to what the website can do and some of the functions, and then we can talk a little bit about it afterwards. So, Clinton, over to you.
Thank you. Thank you for the invitation to share the new SCTS website. As many of you may know, the site has already launched on the 6th of May, just before the meeting. We obviously have the same website address, but we're using a new website company called Light Media, who have extensive involvement with other surgical sites with the college. So why the change? Well, up to now, we've used a number of different databases to run the society, one for the membership, another for finances, another runs the website outcomes. And really all of this has led to difficulties with synchronization and very limited member interaction in terms of getting these information correct. And so the society has taken the opportunity to try and amalgamate all of these databases into one CRM, or client relationship manager, which is housed within the new website. And so hopefully this allows better synchronization of all this data and will hopefully allow a much better member interaction with more accurate data. So the website is large, it contains an awful lot of information, so navigability is really important, and there are 3 ways to gain entry into the site. 1, to understand more about the society, 2, particularly for patients, and 3, for professionals. The About section of the society contains all the information you'd expect into who we are, about the executive, and there's a new section on the history of the society and some interesting information there. But it's the patient's website that has been updated enormously with a great deal more content for patients, both in terms of adult cardiac surgery, thoracic surgery, and obviously congenital surgery. And each of those sections now has an extensive list of procedures that can be explored by the patients. There is also a glossary of terms, which has neat little hyperlinks to other areas of the website to explain text in more details. There's a much improved section
18 months of great work to put this together. Just to stress to the members, this website is for you. It's providing a wealth of resources that we put on there, but we'd also value your feedback to make it a resource that you want to use. So just please communicate with us, please log in, please use the website, and we'll be very responsive to what your needs are as a society. So just again to say a big thank you to Clinton for all the work he's done and will continue to do moving forward with this. So Simon.
Yeah, thank you, Clinton, superb job. We're going to finish this session with Bill Walker's tribute and talk. We're sorry about the glitches and the reorganisation, but actually it's going to be a really nice way to finish this session with Bill's speech to us. So over to Bill.
Mr. President, honoured guests and members of the Society, I wish to thank you for the honour of receiving this award. It should also be something that is considered an award for the co-workers in the City Hospital of Edinburgh and the Royal Infirmary of Edinburgh and the University, all of whom contributed to that programme. I was very fortunate to work with Mr. Evan Cameron, who unfortunately has since died. He made available equipment through our charitable funds.
On the patient journey, which outlines
procedures.
The pre-hospital admission process, a lot of the procedures and process through the hospital stay, right through to follow-up clinics and medication.
We set up with an anterior
we
port,
also still have the way for patients to find either a hospital or a consultant, and there they can link to details of the various institutions and look at the staffing of the units and the outcomes.
We did our first lobectomy in
the front page itself links directly to various news articles, which are updated automatically. And the front page itself also links directly through to an extensive program of courses and events where you can search for events in the yearly view or by the calendar monthly view. And there's a neat little program where you can sort out your specific courses relevant to you according to your career grade.
Do this form of surgery.
Additionally, the education section has been very much boosted with the courses, as we mentioned, but with fellowships being now online and online applications specific.
I constructed a database which ran from the beginning
also
of our procedures.
Links directly to the annual meeting and various educational videos and further training information. 6 months. And in addition, you have links to the podcasts and social media.
About 15 years.
These subspeciality groups have been boosted with
the 7th
more advice and recommendations and guidelines for each of the cardiac, thoracic and congenital lines. And in this area, you'll be able to find more professional data, outcome data and guidelines and advanced techniques.
That made me wonder
There's
whether
also an enhanced nursing and allied health professionals section with again further information on education and research for them. The research area is again bolstered with news, recent trials. There's information about the priority setting partnership and the Cardiothoracic Interdisciplinary Research Network. You still have access to the bulletins, past and previous, and all the other resources such as the blue books, various society reports, and there's a section for useful textbooks to follow with links directly to the online stores and journals with direct links to the online sites. One of the biggest improvements is also the committees. These have been bolstered by having ability to directly link to members of the committee. The committees themselves will be able to manage themselves in terms of emailing members, arranging meetings, setting files, storing files, and I think that they would find this a huge advantage. Similarly, for the BORS group,
on the left column
this will be able to be
many of the starting characters, Fiona Carnahan, our associate specialist,
the
great mainstay of the program, as well
rep for that hospital, as well as the trainee rep.
I have listed below that many of the fellows that work
trust appointed doctor rep will be visible and linkable for each of these hospitals. But it's in the membership area that, again, I think you'll see a big
point out that Johnny
improvement
Ferguson
with
wrote a good paper
easily
training of vasculectomy.
Follow clicks to your bookings, your courses, what applications you've made,
costs were equal when you
you'll also have access to a members directory where you're able to search for other members. You can also take part in various discussion groups. You can create a group and allow to follow various messages from other members.
Through their eyes,
and certainly this may be helpful for a group of trainees, for example.
And
it's really important that we keep our information relevant and up to date, and so I encourage all of the members to actively go on and make sure that their profile is up to date.
From time to
time, a photograph, the correct institution, the correct contact details, which you can specify whether they be visible to the administration, to the public, or to members only.
It's interesting to consider what the future of that surgery may be.
Preferences.
We started with make-do instruments borrowed from other specialties.
Big thank you for
of course,
the support from the Society for setting up the website. And remember, if you're a member, then it's important to log in for a much richer experience.
Will stop.
Happy browsing.
Whether we may move on to autonomous robots, which are already used in industry and have a safety system which operates faster and without the permission of the brain of the machine, and therefore controls the functionality if a danger is anticipated. I should add that Jason Walker, CEO of Waypoint Robotics, is no relative of mine. So perhaps we could have standard VATs for simple procedures, autonomous robotics for straightforward major procedures, and telemanipulator robotics for complicated major procedures. My life with vasculectomy has been a great privilege. I felt we were doing something better. I greatly enjoyed training the young surgeons that worked with me, and indeed working with colleagues in basic science, and meeting and cooperating with surgeons from across the world. I don't know if Dominic Gosso is watching this, but if so, he might remember the many times we met after meetings in the early 90s, wondering why there was so much resistance to VATS procedures, and indeed why the instrumentation was so poor, an issue that he has taken forward very positively. Once again, may I thank the Society for the honour of this award.
Hear the journey that you achieved. I am sitting next to a giant in our specialty. It is lovely to see what you've achieved, and it's a very fitting way to end this plenary session, which I hope everyone's enjoyed. It's time for a coffee break, but Bill, thank you very much indeed for being here, for being able to receive the award.
Thank you.